Today we are going to start types of observational studies. Common studies designs are highly testable in exam. They will ask you what type of studies was performed. The answers will look like this and it will be several studies types. Let's go through each type. Case series used to find clinical findings and symptoms. It describes several individual patients with the same diagnosis, treatment, or outcome. It gives description of clinical findings and symptoms. It has no comparison group, thus cannot show risk factor association with disease. A cross-sectional study is purely observational and it asks what is happening at this exact point in time. Because it takes place in the present time, it collects data from a group of people to assess the frequency of disease and the related risk factors at a particular point in time. It is a snapshot study design. In other words, it gathers data about exposures and outcomes simultaneously. While it can show risk factor associations with disease, it does not establish causality. The characteristic measure for cross-sectional studies is disease prevalence. Now, do you remember what prevalence means? Prevalence is defined as the proportion of people in a population with a disease at any given time. The equation says the number of people in a population with a disease over the number of people that were at risk for getting that disease. An example of a cross-sectional study would be looking at smokers versus non-smokers and their frequency of peripheral vascular disease. Here you're collecting data in the present moment to assess the frequency of peripheral vascular disease within a group of smokers versus a group of non-smokers. Okay, so what is the major weakness of this type of study? So we've mentioned this before, right? While it can show correlation, it doesn't prove causation. Why is that? Let's say we're looking at a particular risk factor and its association with a particular disease. Now, one might rush to conclude that this risk factor in fact causes this disease, when in fact there could be some other risk factor that we're either unaware of or aren't measuring that causes both that risk factor and the disease. So these two things are correlated, but one does not cause the other. A case control study asks what happened. Because it is observational and retrospective, it looks into the past and compares a group of people with disease to a group of people without disease. The cases are the subjects with disease, while the controls are the subjects without disease. And in a case control study, you are analyzing previous exposure. The typical metric for case control studies is the odds ratio, which in this context is defined as the ratio of the odds of exposure in the case group to the odds of exposure in the control group. But how do we define the odds of an event? So the odds equal the probability of an event happening over the probability of that event not happening. Okay, so let's define P1 as the probability of exposure in the context of the disease. And let's define D2 as the probability of exposure in the context of no disease. Now, if we do that, putting everything together, we define the exposure odds ratio as P1 over 1 minus P1 over P2, 1 minus P2. So this together would be the odds ratio. So let's try to make this more concrete by using a specific example. Here we have an example of a case control study where we're looking at exposure to asbestos, which is a material found at construction sites and shipyards and the development of mesothelioma. Here you are looking into the past and comparing cases with the disease to controls without the disease and analyzing their previous exposure to asbestos to see if cases with cancer had higher exposure rates. So suppose the study finds that the probability of exposure to asbestos in patients with cancer is 0.75, while the probability of exposure to asbestos in disease-free patients is 0.25. Now, how do we set up our odds ratio equation for this? Well, we would do 0.75 over 1 minus 0.75 over 0.25, 1 minus 0.25. Plugging the numbers into our odds ratio equation, we get an odds ratio of 9. So a patient who has exposure to asbestos was 9 times more likely to develop mesothelioma. Next up is the cohort study. A cohort study can be prospective, in which case it asks who will develop disease, or it can be retrospective, in which case it asks who had exposure. It compares a group with a given risk factor to a group without the risk factor to assess whether or not that risk factor increases the likelihood of disease. The cohort is the group with the given risk factor, and in a prospective study, you follow the cohort into the future to see if they'd get the disease of interest. The characteristic measure for cohort studies is relative risk. This is defined as the ratio of the probability of the event occurring in the exposed group versus a non-exposed group. And what that looks like is basically just P1 over P2. In this case, P1 is the probability of having the disease if exposed, while P2 is the probability of having the disease if you are unexposed.
This study answers the question, how much more likely is the patient to develop mesothelioma, to use our previous example, if they work at a construction site with asbestos? A different example of a cohort study is the famous Framingham Heart Study. One thing this cohort study examines is uncontrolled hypercholesterolemia and future risk of myocardial infarction. Here, you are looking into the future to see if groups with uncontrolled high cholesterol have a higher likelihood in the future of developing a myocardial infarction. So suppose that P1, or the risk of developing the disease if you have high cholesterol, using our same numbers before, is 0.75, and P2, which is your risk of developing an MI if you don't have high cholesterol, is 0.25. What is the relative risk? Well, this equation is actually a lot simpler than the odds ratio equation, because all we are going to do is put 0.75 over 0.25, and that equals 3. Here's another way to compare case control studies and cohort studies. This point is the present. In case control studies, there are two groups at the present time. One group that has the disease and the other that doesn't. The study looks to the past to find out, were they exposed? So what would a cohort study timeline look like? Well, again, if this is the present day, then you have two groups. All the patients are healthy at this point, but one group has an exposure and the other group doesn't. The study looks to the future to ask who will actually develop the disease. The last two types of studies are twin concordance studies and adoption studies. Twin concordance studies compare the frequency with which both monozygotic twins and both dizygotic twins develop a disease. This measures the heritability of a disease. Specifically, the more concordance a disease shows for monozygotic twins relative to dizygotic twins, the greater the heritability of the disease. Adoption studies compare siblings raised by biological versus adoptive parents to separate heritability from the influence of environmental factors on disease. This is looking at that characteristic nature versus nurture when it comes to complex diseases. Ecological studies. Ecology is the scientific study of the relationships between living organisms and their environment, including both the living, biotic, and non-living, abiotic components. It compares frequency of disease and frequency of risk-related factors across populations. It measures population data, not necessarily applicable to individuals. It also used to monitor population health, like COPD prevalence was higher in more polluted cities. If we go through from this table, there are 3 blocks respective to time. If you focus in past, we do case control study, and also in a retrospective study,
We also review the previous records of past about exposure of risk factors. In present, we done cross-correctional study in which we compare disease prevalence. In prospective cohort studies, we check the effect of risk factor of present and compare the disease's incidence. The cohort study can be prospective or retrospective, but risk factor has to be present before the disease development. It's all about observational studies. Our next topic is the clinical trial. Clinical trials are experimental studies involving humans, and they compare the therapeutic benefits of one treatment versus another treatment or of a treatment versus some placebo. So, what are the characteristics of the highest quality clinical trials? Well, they should be randomized, controlled, at least double blinded. And by that I mean neither the patient nor the investigator knows whether the patient is in the treatment or the control group. So, how can a study be blinded? Well, when the study is single blinded, the patient doesn't know if the pill they got was the real drug or the placebo. However, the doctor and the researcher both know what the pill contains. In a double blinded study, neither the patient nor the doctor knows if the patient got the placebo or the real drug. Lastly, in a triple blinded study, no one knows, not even the researchers analyzing the data, know which pill the patient got until after they have analyzed all of the data. More blinding results in less bias of patients, doctors, and researchers. So, there are four types of clinical trials, also known as phases, and they go from phase 1 through phase 4, each one progressing from one to the next. However, there are also new phase 0 trials that are called first in human or microdosing studies. This is where 10 to 15 healthy volunteers receive single subtherapeutic doses of the study drug to look at pharmacodynamics and kinetics and to confirm in vitro and animal data. Now, because study participants are getting lower than normal drug doses, you don't get any information on safety or efficacy. In contrast, classic phase 1 clinical trials study a new drug in 10 to 20 participants, usually healthy volunteers, and they assess the safety, toxicity, and pharmacokinetics and pharmacodynamics of that treatment. Phase 2 clinical trials study a small number of patients, usually on the order of hundreds, with a disease of interest, and then assess treatment efficacy. What is the optimal dosing and what are the adverse effects? Phase 3 clinical trials study a larger number of patients, often in the thousands, depending on the disease prevalence. Patients are randomly assigned to either the treatment under investigation, to the best available treatment, or a placebo if there is no approved treatment. These studies compare the new treatment to the current standard of care. It is at this point that the treatment may or may not receive FDA approval. And finally, phase 4 clinical trials are designed as post-marketing surveillance trials of patients after drug approval in an effort to detect rare or long-term adverse effects. Take a look at the simplified chart of the four phases of clinical trials to help you remember. Phase 1 asks, is it safe? Phase 2 asks, does it work? Phase 3 asks, is it good or better than the current thing that we have? And then phase 4 asks, can it stay?
Our next topic is off-label drug use. Use of a drug to treat a disease in a form, population group, or dosage that is not specifically approved by the FDA. Reasons for off-label use include
treatment of an illness with no approved pharmacologic treatment, or exploring alternative treatments after failure of approved options. Example: use of tricyclic antidepressants for treating neuropathic chronic pain. Next up, Bradford Hill criteria that are the most cited and applied frameworks to suggest causal inferences. Now, what does this mean? We all know the historic correlation does not imply causation that is preached in pretty much all statistics classes. But what if certain associations do imply causation? Why do we care? Well, why do we champion any public health campaign? Does smoking really cause lung cancer? And what about UV light and radiation on skin cancer? The entire reason the Bradford Hill criteria were made was to determine cause and effect relationships to effectively practice preventative occupational medicine. This is why we care, and this is why we still use these 9 criteria to guide investigations and help prevent disease in the future. And thanks to modern medicine bringing in greater understanding of genetics and molecular biology in response to carcinogens, toxins, and the like, we are even more capable of exploring these cause and effect relationships and understanding the complexity of disease due to exposure. Without further ado, let's dive in. Today, our singular aim covers the entire set of 9 Bradford Hill criteria. Rather than strictly memorizing this list, also found in your first aid public health chapter, I will help you describe each criterion and apply them to a clinical scenario to really make these statistical measures stick. The first criterion we have today is strength. While association does not equal causation, the larger the association, the more likely the relationship is to be causal. Now, how do we apply this? Let's use the same example that Hill did. In the UK, Percival Pott examined the incidence of scrotal cancer in chimney sweeps, the very same ones that dance around the screen in Mary Poppins. He found a very strong strength of association between workplace exposure and disease. In chimney sweeps, the incidence of scrotal cancer was 200 times greater than in other jobs. Increased exposure to chimney soot was found to be the causal factor. Next, let's talk about consistency. This one's pretty easy. Results should be replicable, meaning studies in multiple locations, populations, and using different methods should come to the same causal conclusion between exposure and effect. Repetitive findings when mass produced introduces statistically sound findings that strengthens validity. But see our other stats videos on that. Now, clinically, what does this mean? Well, if you're a Star Wars fan like me, this means in the Clone Wars, no matter where the battle armor is made, no matter when, even if they're constructed differently, we see similar results. While they may not be the exact clones of each other, they're at least coming to the same conclusion. Medically, this means disease, let's say melanoma, is observed to be associated with UV exposure in observational, molecular, and in vitro studies across many different decades and countries. Moving on, let's talk about specificity. This criterion suggests the more specific the relationship, the more likely the exposure causes disease. In today's era, we usually attempt to pin down the dose of exposure to the chemical or biologic agent. Clinically, specificity can then be applied to asbestos exposure to lung disease, such as asbestosis, mesothelioma, and other fibrotic pathologic processes. In modern medicine, we attempt to demonstrate a specific molecular mechanism between the agent and disease pathology. For more on asbestos and lung disease, be sure to check out our videos in the respiratory chapter featuring yours truly. Our next criterion is temporality, and this one is pretty non-negotiable and the only criterion that must be met. Temporality simply states that the cause or exposure must precede its effect or onset of disease. Unfortunately, we all know about the effect of thalidomide on children of women who took the medicine when they were pregnant. In the early 1950s and 60s, women used thalidomide as a particularly powerful antiemetic for morning sickness. However, we did not know how catastrophic it was for the babies, thousands of who died in utero or were born with severe limb defects. This can also be applied to mothers who use DES in utero, whose daughters have increased risk of breast cancer and vaginal clear cell adenocarcinoma. Our next criterion is biological gradient, meaning if a dose response is seen, it's more likely that the cause effect relationship is causal. More exposure, more effect. If you're thinking, Lindsay, this is incredibly simplistic and things are a lot more complex than that, well, you'd be right. Even Hill recognized that a linear dose response rarely ever exists due to individual susceptibilities and environment. Let's apply that to liver toxicity and acute liver failure. Taking anywhere from 325 milligrams to 4,000 milligrams of acetaminophen, also known as paracetamol outside of the US, is generally safe for your body. However, if you ingest a toxic amount, usually over 4 grams a day, a toxic metabolite called NAPQI can accumulate through a known reaction by CYP-mediated hydroxylation. Logical and known dose-response chemical reactions that lead to liver toxicity, which is also an example of our next criterion, plausibility. The plausibility criterion requires a logical mechanism where cause and exposure can rationally lead to effect and disease. Historically, we can use the story of the radium girls as our clinical example for plausibility, which can be backed up by specific molecular mechanisms showing effects ranging at even low doses of exposures. In the case of radium, it decays, releasing radioactive alpha particles that induce double stranded DNA breaks, targeting osteoblasts and bone marrow. These are also common mechanisms taken advantage for modern targeted chemoradiation cancers. But back to our girls. From 1917 to 1926, women were employed as painters for the Radium Corporation to paint luminescent radium lit watch faces. Using brushes for that fine work required pinpoint bristles, which the women used their lips to spin. The motto was lip, dip, and paint, which inadvertently dosed them with radiation, leading to anemia, fractures, and jaw necrosis. To add insult to injury, the company marketed the paint as safe, so the girls also painted their nails, teeth, and skin with radium. Woof, not such a bright idea, hey? Now we have coherence, which in reality is pretty similar to plausibility. Basically, the cause and effect relationship should make sense. It shouldn't contradict known scientific knowledge or processes. Hill used the historic case of observed bronchial epithelium changes with the carcinogenicity of cigarette smoke to relate cigarette smoking to cancer pathology. Today, this is reinforced and bolstered by molecular evidence. And similarly, experiment is another pretty common sense criterion. Evidence derived from experimental manipulation may lead to the strongest empiric support for cause and effect relationships. Going along the same line, thanks to multifaceted experiments with different approaches and our modern medical advancements, we know the exact mechanism by which carcinogens induce carcinogenesis on the molecular level, not only supporting the experiment criteria, but also coherence and plausibility among others too. This criterion uses the basic understanding that if there is a strong established relationship for one cause and effect process, a similar cause can be expected to have a similar effect and can be inferred even if there's weaker evidence for the relationship. Let's consider carbon nanotubes. These respirable fibers are similar in morphology to asbestos and would be expected to have the same deposition, inflammation, and fibrotic response as asbestos if inhaled. Multiple studies have even shown the similarities in response. Therefore, despite carbon nanotubes not having as robust of investigations or concrete associations as asbestos, previous studies to the later demonstrate a strong assumption for causal relationships between carbon nanotubes exposure and lung inflammation and disease. And that sums up our discussion on the Bradford Hill criteria. All right, next up, we're going to talk about quantifying risk. And here we'll use the 2 by 2 table to create formulas as well as help simplify these wordy concepts. As you may have gathered by now, having a decent grasp with this 2 by 2 table is key for most of your biostats questions, and it's going to show up on all levels of the USMLE as well as COMLEX. All right, let's get started by talking about risk, looking at the odds ratio. Do you remember what type of study uses the odds ratio? There you go, case control studies. Now, the odds ratio is formally defined as the odds of exposure to the risk factor in the disease group divided by the odds of exposure to the risk factor in the non-disease group. Or if we were to put this more simply, does the exposure to the risk factor increase the odds that you have the disease in question? And if it does increase the odds of disease, how strongly is the exposure associated with the disease? In statistical terms, this means that the exposure is more associated with disease than chance alone. So, looking at our 2 by 2 table here, we can compute the odds ratio in 3 easy steps. And this will eventually become one easy step. Alright, so first up, we need to determine the odds of an individual having the disease, given that he or she experienced an exposure. This can be written as A over C, where A is people with both the disease and the exposure, and this is divided by C, which is the number of people who got the disease without being exposed. In our second step here, we need to figure out the odds of developing the disease without an exposure. This can be written as B over D, where B is people with an exposure who are healthy, divided by D, which is the number of disease free, exposure free individuals. And for our third step here, we're going to compare the two groups and quantify our odds ratio. To do this, we divide step 1 by step 2, and it works out as follows. And here you can see that the odds ratio equals A over C divided by B over D. Next, we can simplify this equation and it becomes A times D divided by B times C, as you can see here. Now, if remembering the derivation actually helps you go through all the steps here, otherwise you can cut straight to the chase just by memorizing this equation. So, with all that, does the odds ratio imply causation? Absolutely not. It actually only implies correlation. Here, you could have a third variable or a co-founder that is both associated with the exposure as well as disease. So don't get fooled. The big thing to remember here is that odds ratio gives you a correlation but not a causation. So what if you have a really rare disease with a very low prevalence? Here, the odds ratio actually approximates the relative risk. All right, so now let's take a crack at a flash quiz. What type of study uses a relative risk as a measure of association? There you go, that's going to be a cohort study. All right, now let's just hop right into relative risk. Now, relative risk is formally defined as the relative probability of getting a disease in an exposure group compared to an unexposed group. Here, it is calculated by the fraction with disease in the exposed group divided by the fraction with disease in the unexposed group. So from our table here, we can figure that relative risk is calculated as A, which are people with the disease and the risk factor, divided by A plus B, which is all the people with the risk factor, over C, which is people with the disease but no risk factor, divided by C plus D, which is all the patients with no risk factor. And just to make sure we're clear here, A stands for people with the disease and the risk factor, and A plus B stands for all the patients with the risk factor, and C stands for those with the disease but no risk factor, and C plus D are all the patients with no risk factor. Now that we have the formula for relative risk, let's discuss what each relative risk value represents. Now, if the relative risk value equals 1, then there is no association between disease and the exposure. And if the relative risk is greater than 1, then you know the exposure is associated with increased disease occurrence. Or to say this another way, the exposure here is protective against the disease. So, for an example here, if you take the exposure of smoking, it is likely to have a relative risk greater than 1 for coronary artery disease, while exercise likely has a relative risk less than 1 for coronary artery disease. Now, relative risk reduction is directly related to the relative risk, and it's defined as the proportion of risk reduction that is attributable to the intervention as compared to the control. So, to put that as an equation, the relative risk reduction equals 1 minus the relative risk. So, for an example of this, let's say you're on the Titanic and you're giving out life jackets. And let's say 20% of the passengers that get life jackets drown, whereas 80% of the passengers without a life jacket drown. So, from this, if we wanted to calculate the relative risk, it would be 20 over 80 or 25%. And now, if we wanted to calculate the relative risk reduction, it would actually be 1 minus the relative risk, or 1 minus 0.25, which would equal 0.75 or 75%. So, the relative risk reduction of drowning with a life vest is 75%. So, now let's discuss another important parameter when quantifying risk. This will be the attributable risk, which is the difference in risk between the exposed and unexposed groups. To ask that another way, it's how much more does a specific exposure place the patient at risk. An example of this might be a patient jumps off one stair versus a patient jumps off 13 stairs. How much extra do the 12 stairs contribute to the risk of spraining his ankle? Now, the attributable risk is calculated as A divided by A plus B minus C divided by C plus D. Here, A plus B is everyone with a risk factor and C plus D is everyone without a risk factor. So, for another example, if the probability of getting pneumonia in a smoker is 2/3, while in a non-smoker it's 1/3, we could conclude that the proportion of pneumonia occurrences attributable to smoking would equal 1/3. Next up, we're going to talk about the absolute risk reduction. And this is the decrease in risk associated with an experimental treatment as compared to placebo or the control. Here, the attributable risk, as we just talked about, and the absolute risk reduction are important because they are used to calculate the number needed to treat and the number needed to harm. All right. Next up, we're going to talk about absolute risk reduction, and this is the decrease in risk associated with an experimental treatment as compared to placebo or the control. The formula for absolute risk reduction is C divided by C plus D minus A divided by A plus B. And what formula is this fairly similar to? There you go, the attributable risk. So here, if you can remember one of them, the other one is just the other one. Now, the attributable risk and the absolute risk reduction are important because they are used to calculate the number needed to treat as well as the number needed to harm. Now, to calculate the number needed to treat, it's 1 divided by the absolute risk reduction. And to calculate the number needed to harm, it's 1 divided by the attributable risk. Now, the thing you need to remember here is the formula for number needed to treat and number needed to harm. Questions will often give you the attributable risk or the absolute risk reduction, and all you have to do is plug this into the number needed to treat or number needed to harm formula to come up with the answer. You can think of number needed to treat as the number of people you need to give an experimental treatment to prevent one person from getting the disease of interest. And in contrast to this, the number needed to harm is the number of people who would need to be exposed to a risk factor in order for one person to acquire a disease of interest. All right. Well, that's going to wrap up.